Hello, my name's Julie McCrossan, and it's my enormous pleasure to welcome you to the first of our debates on MSF TV. Over the next 4 weeks, we're going to look at major health issues and what we can do to help the people affected by them. And we're beginning with the eradication of tuberculosis and HIV AIDS. And I've got 4 people who are actively involved in the fight to eradicate HIV AIDS and tuberculosis. It gives me great pleasure to begin by introducing Dr. Daniel O'Brien, who's an infectious diseases specialist, an internal medicine consultant, and a medical doctor who's worked in over 30 countries for MSF, which is absolutely amazing. Welcome to you. I'm also pleased to welcome James Gilling, who's a First Assistant Director General with AusAid, an economist by training with extensive regional experience, particularly in PNG, East Timor and Indonesia. Welcome also to Dr. Suman Majumdar, who's a medical doctor who's worked for MSF in part of the former Soviet Union. His passion is the eradication of tuberculosis. And Suman has a Master's in Public Health and Tropical Medicine, and you're currently doing some extra specialist training in Darwin on infectious diseases. And also Bill Botel AO, who's Executive Director of Pacific Friends of the Global Fund to Fight AIDS, Tuberculosis and Malaria. And Bill is a former diplomat, a senior policy advisor and a key architect of, the fight against HIV/AIDS here in Australia and beyond. So on behalf of our audience, I'd like to welcome all of you. And what we're going to do over the next 30 minutes is have a look at the scale of the problem, who's affected, some of the great things that are currently being done to eradicate, to treat and eradicate HIV/AIDS and TB, the key challenges you face and the priorities for the future. So let's begin with the scale of the problem. And I want to start with tuberculosis because we don't hear as much about it. Suman, what is tuberculosis and how big is the burden of disease globally?
So tuberculosis is a disease caused by the bacteria, Mycobacterium tuberculosis. And it's a disease that the world's forgotten of late, and it's re-emerged as a serious threat to global health. It was the leading cause of death in the 19th century. And we've then discovered drugs to treat it some 60 years later. With development and improvement in other measures, TB then was thought to be controlled. Since the 1980s and 90s, it has re-emerged as a real problem. Currently, it's thought annually there are about 8 million people each year with tuberculosis. There are 2 million deaths. And the epidemic's been fueled really with the emergence of 2 things. Drug-resistant tuberculosis, TB that normal first-line drugs do not treat and cure. And secondly, the HIV epidemic. It's really fueled TB globally.
Help me understand that. What's the link between TB and HIV?
Sure. So in people with HIV, TB is the leading cause of death, is a key point there. People who have HIV don't have an immune system, and TB is one of those infections that can come in and affect those people. It's because our tools currently are not good enough to diagnose it and to treat it early enough. TB spreads quite quickly through people who have low immune systems.
Suman, I'm going to come back and talk to you about some of the work that is being done that is effective and also the challenges. But in a nutshell, your position is our approach to TB and getting rid of it is just not good enough. Why not?
Correct. I absolutely agree. It's not good enough because the disease is re-emerging as a massive problem. People do not have access to treatment. They're not getting diagnosed. They're not getting the drugs that they need. And this disease is curable. You can absolutely cure someone with TB.
Look, let's come now to Dr. Daniel O'Brien, who's been working, as I said, in over 30 countries for MSF and particularly around HIV. We've heard a lot about HIV and AIDS, but where are we up to, particularly globally? How big is the burden of disease and where are the major problems?
Well, I think HIV is still a really large, significant global health problem. And I think the other major thing about it is that it affects populations in resource-limited settings mainly, but also marginalised, neglected. Those are often excluded from health systems as well. So it's a vulnerable population that often affects. And the global problem is huge. I mean, it's estimated about 35 million people are infected worldwide, and probably there's about 3 million deaths annually still. So it really is a large problem, but I think I'd just like to personalise it to the fact, in some of my work, for instance, in rural villages in Zambia, where you go to a community and in fact there are children looked after by grandparents, but there are no parents. There's a generation that's being lost through the death and morbidity from HIV/AIDS. And I wonder to myself when I'm there, have we ever as a species been faced with such a health problem that takes away, you know, the most important part of our society as far as the caregivers and the earners? And it's really dramatic.
Daniel, that's a very good question. Have we ever been faced with I mean, are we talking the bubonic plague if we're going to look for something of comparable scale?
Certainly in my lifetime I haven't seen it, but perhaps in the past. But it's really striking. It's not only an individual disease that affects an individual, but affects the families that they're involved with. It affects the communities, and it affects whole societies, because it's a health problem, but it's an economic problem. It's a societal problem, and it just spreads throughout whole communities, and therefore the impact is enormous.
Well, look, I want to spend as much time as possible in this session on what we're currently doing and what more needs to be done, because MSF and everyone watching this is interested in the action side. I'll stay with you, Daniel, on HIV. You've worked in over 30 countries. That seems extraordinary. Give us a snapshot of the kind of work you're doing around HIV that actually makes a difference, with examples from a couple of the countries you've worked in.
Look, I think the biggest thing, the greatest thing for me about treating HIV/AIDS is that you've got a situation 10 years ago, for instance, in many of these resource-limited settings where people coming to your health facilities dying slowly in terrible pain, unable to work, unable to look after their families, who you knew with drugs that were available in richer countries could be saved. And I think as a doctor that was a terribly frustrating thing, and it's been extremely exciting and satisfying to see the huge improvement in that situation where people now can access treatment and really regain full health. And for me, one of the most satisfying things I've ever done in my medical career is to sit amongst a group of people on treatment for HIV/AIDS, see their life, their vitality, the fact that they're well again, knowing that everyone in that room would have been dead if it wasn't for the fact they were able to access treatment.
So life-saving treatments is a key progressive issue here where we're achieving something. But aren't there challenges around equity of access to those treatments because you're forced to ration in certain circumstances?
Yeah, I think the thing is, there's been great developments, but there's still huge challenges. And one of the greatest challenges is we're still at the best treating maybe 40% of people who currently need treatment, and there are more and more people who will need treatment in the future. So there's still huge challenges around access to treatment, as well as funding for treatment, as well as trying to make treatments more safe, more effective, to make them cheaper, to make them better adapted.
Is it possible to give me an example of a country where you felt that stress of the need to ration most acutely personally as a doctor?
Yeah, look, I think Burma's the classic situation for me, where a country with a huge needs for HIV care, but on the other hand, very limited resources and very limited actors actually providing care. So for MSF, for example, has provided over 80% of treatment in Burma itself. And in that situation, the numbers requiring treatment are just far too many for what our organisation can actually do. So we've been forced to rationalise our treatment to the people who are the most sick, which I guess the most in need, but ideally you've been treating people before they get sick, one, so that they don't die, because you still have a high risk of mortality if you leave treatment too late, but two, so that there's also a significant prevention component to treatment as well, to help try and put the brakes on the epidemic as well.
Of course, because MSF and other organisations are keenly involved in education and awareness raising, as well as the direct diagnosis and treatment. But I just want to ask you one more thing before we come to tuberculosis. My understanding is that in the 30 countries you've worked in as a doctor, working with people with HIV, you've developed some new models of care. What is a model of care, and what have you developed that you think is so good it should be extended?
I think the thing for me is 10 years ago people said you couldn't treat HIV in resource-limited settings because it was too hard and too complex. Now, one of the great achievements has been to take the care that was provided in resource-rich settings and adapt it to resource-limited settings.
So an example?
An example of this is task shifting. So most of the care provided in Africa and many places in Asia is not provided by doctors and not necessarily by nurses, sometimes even experienced patients who know a lot about the disease. But transferring some of the care and responsibility to lower level healthcare workers has made a huge difference because of the vast shortage of healthcare workers. You can't do it without that. But I think other things is just the tools. I mean, to have a test for HIV in Africa, for instance, you just need a test with a little finger prick of blood, which takes 15 minutes, where previously it might have taken a few days. And just having the access to diagnosis is, of course, so important to access care, and that's been a major step. But there are many examples of where tools, the way the treatment's provided, the way it's been adapted, has really made a huge difference in making treatment available in these settings.
Look, I'd like to come to James Gilling just for a moment. James, of course, is a First Assistant Director General with AusAid. And just to look at the contribution AusAid has made in our region towards the treatment and elimination of HIV and AIDS. What is AusAid and what are you doing about AIDS?
Well, Julie, AusAid is the government agency that manages the overseas aid program. We have an aid program this year that's worth over $5 billion, and AusAid is in charge of managing that and providing advice to the minister. We have a role in a whole range of sectors, and one of them is the health sector. And within the health sector, there's little that's as important as HIV and TB and indeed malaria. And our responsibility here is to provide funds to address the problem that we've been hearing about so far. And as you rightly pointed out, in our region we have a particular focus. We work in Indonesia. In relation to HIV in Indonesia, we have a very large program worth about $100 million that works on the transmission of HIV through injecting drug users. And we've had some very dramatic impacts. As I understand it, we can see that some of the incidence rates for drug users, intravenous drug users with HIV in prisons in Indonesia has come down from over 50% to just 42% as a direct result of some of the assistance that we're providing.
We've had a bit of media coverage here in Australia about problems with HIV AIDS in PNG. What are we doing there from an AusAid perspective?
Well, PNG is a fascinating issue, and again, at the start, several years ago, there was major concern that in PNG we were on the cusp of seeing what was described as an African-style epidemic, where we would see rates of 3, 4, 5%. Immediately, AusAid became involved and engaged very intensively, not only with the government, with civil society, to bring about a lot of investments in treatment. And we now have a situation in PNG where, thankfully, we haven't progressed to the sorts of levels that we thought we might get, but we now have over half of people in PNG with HIV who are currently receiving treatment, which is great progress. And we have AusAid providing in 2010 over 3/4 of all resources in the country that went to fighting HIV.
Can I just ask you, my understanding is that with HIV AIDS in PNG, and it may be so in other parts of the world, sexual assault can be a factor in transmission, and that has been a sensitive issue in PNG. Does an organisation like AusAid endeavour to help people deal with something like that? I guess a social context that has a health impact.
I mean, the first point to make is that AusAid's mandate is the reduction of poverty. And poverty is not just an income issue. It's also about rights. It's also about the way that people experience their lives. And as you rightly point out, violence against women is a massive dimension of that poverty, so it's core to our business. We've actually done a lot of work in Melanesia, which is Papua New Guinea, Solomon Islands, Vanuatu, to look at rates of violence against women which are amongst the highest in the world. In fact, I think you'd struggle to find anywhere higher. So we do take that very seriously. We do work on there, but you raise a very important point that in each country, the nature of the disease, the nature of the transmission of the disease is different. And in Melanesia, tragically, the issue of violence against women is an important part of that disease and how it's transmitted.
A little later in our conversation here, we're talking about the eradication of HIV AIDS, and in a moment we'll be talking about tuberculosis. But I want my panel to help me remember to talk specifically about the needs of children. But we'll do that in a moment. I want to come back to Dr. Suman Majumdar, who is someone with a passion for the eradication of TB. What are some of the key initiatives that are making a difference? You talked before that not enough is being done, but what is being done that you think is helping?
Just before I answer that, I will add that talking about HIV in PNG, I mean, tuberculosis and specifically drug-resistant tuberculosis is a massive issue there. Reports done by groups have shown prevalences of up to 40% of drug resistance in patients there. This was, it's a topical area. There's been an MSF program that's working in 2 regions of PNG, and discussion about trying to help these patients who do have this form of the disease.
Explain what drug resistance is and why it has such a devastating impact. Because the treatment of TB has to be done over time, doesn't it?
Absolutely. So drug-resistant TB is resistance to the best 2 antibiotics. So usually someone with tuberculosis, we can cure it with 4 drugs and they're given over 6 months, which is a short course. Before it used to be 2 years, but it's still relatively a short course when you look at the benefits of giving those drugs that are cheap, effective and work. Drug-resistant TB, or DRTB, is resistant to the best 2 drugs, and therefore you have to use a whole new set of drugs, the second-line agents. Now, then we revert back to older drugs, and these drugs are toxic. They're horrible to take for these patients. You know, the patients I was treating in the former Soviet Union, they'd all get side effects: horrible nausea, vomiting, rashes, and even mood effects from some of these drugs. The treatment lasts for a minimum of 2 years, and it includes an injection for a minimum of 6 months every day, a painful injection into the buttock. So, that's really not good enough, to treat this disease, which is curable, as I said.
And so, are you saying, Simon, if we talk about future priorities for action, new medications to deal with TB is critical?
Absolutely, yeah. And the 2 things are getting a diagnostic test and getting better treatment. They're the 2 things we need to do.
And new diagnostic tests for tuberculosis are in the pipeline, aren't they?
Absolutely. There are pipelines, and one of the biggest progresses has been trying to pursue this holy grail of what we call the point of care test, where someone shows up to the clinic and the healthcare worker or the doctor needs to decide if they have TB or not. It's very difficult in people who have HIV and extremely difficult in kids, and those are the other 2 groups that diagnostics are very limited. In 2010, the WHO approved the rollout of this machine, which is a rapid diagnostic test called the Gene Expert, and within 2 hours it gives you an answer of whether that person's got TB, yes or no, and whether they've got drug-resistant TB, yes or no. Okay. And that was, that's a good success story. It was a private-public collaboration, research brought to the fore and then put into the field. However, there are challenges around that. The uptake has been slow, and there are still some issues around that test. It's not a true point-of-care test because you still need, gets a bit complicated, you still need to back up that diagnostic test with a sputum culture, which requires a specialised lab.
Okay. Sputum culture is basically someone has to spit into something and then it has to be tested.
Absolutely right, yeah.
I point that out just that in many of the countries that MSF works, I assume something like a sputum culture that would be done in one of our acute hospitals in Australia quite quickly could be a really major issue. Yeah,
look, the world of TB diagnostics is a century behind. I mean, since in 1882 we discovered the bacteria, it was using a microscope, and the first step is using a microscope, and that's been the stock standard diagnostic test for these clinics. But you need skills to do that. You need to know how to look under a microscope and see these bacteria in that sputum. That's backed up by the culture, which then gets put onto a plate and sent to a specialised lab where it grows.
Look, what I want to do, if I may, is come to Bilbo Tell, because we've been talking about the need for new medications, and even though with tuberculosis you now have a shorter treatment regime, I assume if you could make it even shorter, you'd help even more people. And when we're talking about drugs, we're talking about money, and the Global Fund is essentially, is it about attracting more money to the fights we're talking about now, HIV, tuberculosis, and I think also malaria?
Yes, well, the Global Fund to fight AIDS, TB and malaria was established 10 years ago, 2002, and it was established to address exactly this question of providing money at scale to allow treatments for AIDS, TB and bed nets for malaria to be spread to the countries where they were most in need. From 1996, an effective treatment had been developed for HIV, but the scandal was it was not getting to the countries and regions in the world that most needed it. The rich countries were able to look after themselves, of course, so in a country like Australia, everybody who needs HIV treatment has access to it. But in Africa, Central Asia, Papua New Guinea and other places, the treatments were there in theory, but not in practice. So the question is, how do you find the billions of dollars that are necessary to underwrite the provision of treatments for AIDS and TB?
How do you?
Well, from 2002, I'm happy to say that with the support of the Americans, with the big donors in Europe, with Japan, with the Bill and Melinda Gates Foundation, the billions started to roll in, and crucially, this was new money. So
Because
in
you
the
did
last
have
decade,
some troubles with the Global Fund for a while, didn't you, in shortages?
well, I think the problems with the fund, the challenges of the fund in the last few years have been related to its success, because the uptake of money has been quite spectacular. It's been $30 billion that's been raised out of the international community in 10 years, and effectively distributing this through the countries, because the Global Fund does not run the programs itself. The countries themselves are responsible for putting plans to the fund. The fund funds those plans, and then the treatments have to be rolled out, not just in the capitals, but in the clinics far away from the capitals and provincial centres. They have to be recorded, administered, and this is a difficult question to do at scale, but it's been very effective.
What's the single most important priority for action when it comes to attracting sufficient money to eradicate TB and HIV at scale, as you call it? You know, what's the challenge we're facing in the next 5 to 10 years?
10 years ago, the amounts of money were small in comparison to the budgets of the developed countries that fund the Global Fund. Now the amounts of money required are big. If we're going to get to give HIV treatment, for example, to all the people in the world who require and demand it, then we are going to have to find many, many more tens of billions of dollars. Now next year, the Global Fund goes to the international donor community for what's called the replenishment. Every 3 years it says to the international community, please fund at scale the increased demand for HIV/TB treatment. However, there is an international economic crisis that is hurtling its way through the economies in America, in Japan and Europe, and they are finding it increasingly difficult to make that commitment to the fund. So our big challenge is to convince the politicians in the developed countries and public opinion that the demand is there, that we can do something effective about it, and that the fund should be funded to make those treatments available.
It's my understanding that Hillary Clinton has made a statement that we could have an AIDS-free generation. How important is it in that kind of global advocacy for support for people like Hillary Clinton to be talking about it, but also is it possible?
It's absolutely possible. There is no magic bullet required now to do what is necessary to reduce, for example, 300,000 children are born with HIV each year. We know exactly how to reduce that from 300,000 a year to zero.
How?
To have an HIV-free generation by providing the treatments to mothers to ensure that their children are born without HIV. That can be done. It is simply a question of money, and money is a question of political will. I'm happy to say that in the United States, Hillary Clinton, but also backed up, it has to be said, by a very broad cross-section of opinion in the United States. Mitt Romney and the Republican Party the other day put in very effective messages of support for funding the Global Fund should Mr. Romney become president. So there is a united will to do something, but it's got to be approved by the Congress and by the politicians and put into budgets.
And Bill, is one practical thing we could do, watching this and in our various areas of work, to start talking about tuberculosis as well as HIV/AIDS, because Suman explained to us earlier that they're intimately connected in terms of cause of death of individual patients.
Well, one of the great, well, I wouldn't say it's a great thing, but this attention to TB that's come out of the HIV problem has been really salutary. Now, the Global Fund provides now about 80% of all international funding for tuberculosis treatment at the moment. And we need to attract even more money into both treatment, but into the point that Suman made, a very important one, that it's a 19th century set of tools that we have to deal with it. And if we've got that money into TB, then that attracts more money for research into diagnosis, into upgrading the technologies and research and so on that we need to really get on top of TB as well.
I'd like to come back to Daniel, our medical doctor who's worked in over 30 countries with HIV/AIDS, and talk to you a little bit about children. Are there particular needs of children that we we should focus on as we go forward?
Yeah, absolutely. The first thing I'd always say about children is that the most depressing thing, as Bill's touched on, is to know that every child with HIV that you see, although you can treat and keep alive, shouldn't have had HIV in the first place, because we don't get children in Australia with HIV anymore because it's completely preventable. So money is one thing, but there's also about systems and training and tools and better drugs and better simplified protocols which come to that. But the bottom line is that they shouldn't be infected. Having said that, they do provide specific challenges in that most of the drugs which we've used with great success are actually being developed for adults, and they're not in forms that are easy to take for children. They're not in forms that have been tested for children, especially the newer, more effective drugs. We still really lack specific paediatric formulations.
Why is it taking so long? Why aren't children so vulnerable?
I mean,
we're keen to help.
Even up until 2005, 2006, very few children were actually being treated because it was felt that it was too hard, it was too difficult, and healthcare workers were struggling with the fact that they just didn't have the tools to diagnose and to treat children. Now, progress has definitely been made in that area and more children are being treated, but they still lag behind adults, there's no doubt about that. And the main things I see is the difficulties in testing and administering treatment to children.
So it sounds like, in terms of key challenges going forward and things we need to address, diagnostics for children, treatment for children. Help me, where are we up to with the antivirals and their capacity to stop transmission between adults?
Well, basically they're highly effective, and you can quote different studies, but somewhere if somebody's taking their tablets well and they're effective, then the risk of transmission is in fact extremely low. So the classic case is couples where one person is positive and the other one's negative. You can basically protect that person by putting them on treatment. And that's the most exciting thing for me, is that there is hope on the horizon of eradicating HIV now, because what we've been doing now is trying to catch up with all the people that have it and treat them, but now we know that every time we're treating somebody, we're also likely preventing infections as well, and that's incredibly important. And I think the classic is, in the case of the pregnant mother, who if she accesses treatment, not only will her child become HIV negative, but she'll also remain alive around to look after that child and help them grow and maintain that community context that we talked about earlier. And so there's a real emphasis on having the money to support the extra drugs, but also working on the mechanisms and also the resources to actually diagnose people who have HIV and get them on treatment early before, one, they get sick, but two, before they transmit the virus to others.
Look, thank you. James Gilling from AusAid.
I wanted to just add into this conversation, I think it's very important that we do emphasise the importance of the availability of treatments, and as you say, treatments that are appropriate for children as well as for adults. But there is an additional dimension that we have to put on the table, and that's that it is not as straightforward as simply having the drugs available. One of the great challenges of Papua New Guinea, for example, it's the world's second least urbanised environment. It has 85% of its population living in places that can be days' walk from the nearest motorable road. And it is in these contexts that it is difficult to get the drugs in the right condition. And when we talk about tuberculosis and the complexities of dealing with drug-resistant tuberculosis, the regimes, the discipline that is imposed. Just imagine places in Western Province of PNG which are only accessible by boat, where the nearest electricity is several days' walk away. And this is about, so it's not just about the quality of the drugs and the availability of the drugs. There is a complexity about how we get the drugs to the point where they're being used, and how we make sure that we can monitor, and how we make sure that the resources are provided, because if you need to have the resources for a full 6-month period, well, you better make sure that the money from the capital is being released on a predictable basis. Otherwise, at month 5, you're not going to have any more drugs to apply.
On MSF TV, we're going to be showing in-depth interviews on many of the issues we've touched on, and also short videos throughout the month of October showing you work that's being done and illustrating some of the challenges you've just said. We only have a few minutes left in this discussion. I want to come back to Suman and tuberculosis. What's the single most important thing you're going to be fighting for over the next 5 years as a young doctor wanting to make change for people with TB?
Look, I think, as I said, these are curable diseases, and we need to get people with the disease diagnosed, treated and healthy. the mortality is high and the loss of livelihood is very high. They can run through communities. I think the single most important things we can do is, well, it's twofold. I'll have two if that's all right. Getting a diagnostic test for the patient in the clinic, and then getting short, simplified treatment, especially for the vulnerable groups of people with HIV and kids.
What attracts you to this work? There's a lot of health staff watching this, and they're thinking, should I become someone who goes out into the field? What attracts someone like you to go to parts of the former Soviet Union I haven't even heard of to try and help patients?
Well, I think we're all, here for one common cause. I mean, it's the first principle of MSF's works and other NGOs. It's humanity. It's looking after others and needs of people that are vulnerable, sick, and need access to care. So I think that drives most of this work. And I think, as Bill alluded to before, the sad part of all this is that we do have mechanisms and ways to help these people. We need to just get the balance right and get it to where people need it most.
I'm going to give my final comment back to Daniel, another of the doctors on the panel, as MSF has obviously the focus on doctors and health teams. And I know you're particularly interested in areas of armed conflict and also neglected populations and neglected people. And we're going to look at both those groups in the coming up debates over the next 3 weeks. What are the critical challenges but also achievements in relation to patients in armed conflict zones and neglected groups that are your passion?
I think my passion is that if you're a healthcare worker anywhere in the world and you have somebody who's sick and dying with HIV, that you have the ability to treat them and keep them alive, because that's the basic tenet, is that they have a right to healthcare and you know that the treatment's so effective and that you can make them healthy again. And so I think the thing for me is that in many places people have looked at it, and conflict's a classic example, and said it's just too hard, it's not possible. And James touched on it. One of the huge challenges is adapting and making accessible treatments in difficult to access areas. And conflict's a classic example. And I've been very proud to be associated with MSF to actually fight the dogma that you can't treat HIV in conflict areas, and we've done it in many places and shown that it's extremely effective. And it includes things like prisons, it includes very remote and rural populations that are difficult to access. You can do it, but you need the will and the support and the systems in place to allow that to happen. And that's where the challenge is, so that the healthcare worker with the patient in front of them is able to provide the life-saving care.
Look, gentlemen, you've been a fantastic panel. I think you'll agree that we've had a sense of the scale of the problem, some of the great work that's being done, the outstanding challenges and the priorities for action in the future. Over the next 3 weeks, we're going to look at natural disasters, we're going to look at conflict zones, armed conflict zones, and also neglected people. We've had 4 gentlemen this week. Next week we have 4 women addressing the issue of natural disasters. We'd love your comments and your questions. You can go to our Facebook page and you can also tweet. Just go to hashtag MSFTV. Just use hashtag MSFTV. My name's Julie McCrossan, and I really look forward to you joining us again, and make sure you explore the whole site because there's so much more information. Thank you very much and goodbye.